In 2004, a community paramedic stopped by the home of an 80-year-old female who had just been discharged from the hospital a few days earlier for pneumonia. "Thank goodness you're here," she said. "I was just about to call 911." The community paramedic said, "Well, that's okay. I'm a community paramedic. Why don't you tell me what's going on? And if we need to call 911, we will." She said, "Honey, I just don't feel any better. My cough is back. My fever's back. I'm short of breath all the time. I was feeling better when I left the hospital, but I think I need to go back in." So the community paramedic did her assessment of the patient. And because she had been trained as a community paramedic, she, in addition to asking the typical questions, asked, "Well, have you taken the medications that they gave you when you were discharged from the hospital?" And the patient said, "Do you mean these?" And instead of handing the community paramedic the pill bottles, she handed her the scripts. "Yeah, those," said the community paramedic. "Didn't you have a chance to get those filled?" She said, "Honey, I can't afford them. And even if I could, I'm 80 years old. I don't drive anymore. I don't have anybody to take me down to the pharmacy to pick them up." Could this patient happen in your service area? This is happening across the country every day, thousands of times a day. And what do we do about it? Well, in this course, Beyond the Body, what I hope to show is that there has to be a different way for dealing with these types of problems. I want you as a clinician to understand that there are things beyond the behaviors, the genes, and the germs that affect your patient's health. And because the U.S. system really is geared towards medicine and not towards the patient, we tend to ignore all of these other factors that may influence your patient's ability to recover or cope with their disease. It's my hope during this semester that you'll reframe the patient. You'll look beyond the body of the patient to all of these other factors that can influence their health in order for you to be a more effective clinician. To do that, I'm going to use the context of this new movement in emergency medical services called community paramedicine and mobile integrated healthcare. It's a way of looking at not only the patient, but the entire system designed to figure out if there is a better way for dealing with patients like the 80-year-old female that we just discussed. So let's talk about that 80-year-old female. In a traditional system, we would not have been there at all, right? We would have waited for the patient to call 911 before we showed up. But as a community paramedic, since we schedule these visits after their discharge from the hospital, we were there before she needed to call us. But let's say in a traditional response, she had called 911. What would we have done? Well, we would have done our patient assessment, taken her vital signs, done a sample history on her, really figured out what was going on. And then what we would have done is treated her like another shortness of breath call, right? Maybe given her some oxygen, maybe given her some medications to help her breathe easier, as we put her in the back of the ambulance and transported her back to the only source of definitive care that is available to us in traditional 911, and that's the emergency department. But the question is this: would that scenario, would that traditional scenario that plays out thousands of times a day across the U.S., would that help this particular patient with her underlying issue? Sure, it would probably help correct the shortness of breath, but it really wouldn't get to the root cause of why she was still sick, and that is she doesn't have access to the pharmacy because she doesn't drive anymore and doesn't have anybody to take her, and she can't afford the medications. Nothing in the traditional system, the system that we have in place today, is going to help her deal with those things. And so this movement of mobile integrated healthcare says, stop. Let's figure out what we can do with the resources we have in place today to change her outcome. What can we do? Well, let's look at this process and figure out if there's a different way for us to deal with that call. When she calls 911, maybe what we need, instead of having a dispatcher immediately send out an ambulance, is maybe having a nurse help to triage those calls. Now, look, if you've been in EMS for any length of time, you realize that every call to 911 is not a life-threatening emergency. In fact, very few of them are. In fact, a certain portion, maybe a small percentage of them, don't need 911 at all. It's not worth sending out an ambulance because the issue is so non-acute. It's not life-threatening. It's not limb-threatening. It's not even a medical emergency at all. The patients oftentimes call 911 to figure out whether they need to call 911. And in those cases, what can we do differently? Well, some systems across the country are starting to put a nurse in their 911 center and triaging those calls to other resources. They're treating an ambulance like it's a prescription from their medical director from their system. And some patients just don't meet the criteria to have that prescription given to them. And so a nurse works with them either to schedule an appointment with their primary care physician or to encourage them to seek care in an urgent care center or some other clinical setting that's more appropriate than sending out an ambulance, lights, and siren to deal with whatever they called 911 for. Now, that assessment phase, when we actually do get on scene and figure out what's going on, we're going to talk a lot about that in this course. Let's go to the next one in stabilization. Let's figure out what we can do differently there. Well, sometimes the issue that's facing the patient needs to be assessed by people on the scene. Somebody needs to get their eyes on the patient, their hands on the patient to do the vital signs. And it's not until you have that data set that you can make a decision as to what's appropriate for that patient. But sometimes what you find during the course of that assessment is that the patient is subacute. They really don't need that emergency medical response or a trip to the emergency department. Sometimes what they need is just a script or just some sutures or something relatively minor. And so what some cities across the country are doing is partnering with advanced providers, people who are autonomous clinicians who can go out on these 911 calls, who can do the intervention on the scene, freeing up the emergency department from a backlog of patients that they can't handle that need relatively minor procedures done, and having the providers treat the patient on the scene as if it's a mobile clinic. They can bill for those procedures as if they're doing a house call, and it frees up the ambulance services to respond to more emergent matters. Now, in some systems, they've gone so far as to say, look, everybody that needs an assessment done and everybody that we stabilized, just because we do that intervention does not necessarily mean that the emergency department is the most appropriate venue for their care. And so what they're looking for is an alternative destination. Look, if you have a drunk and you've done your assessment and you've stabilized them, they're just drunk. They're not hurt. They don't have a head injury. You've ruled out any other thing that could be contributing to their current state. You've looked at that and you've decided that they really just need to sleep off their drunk. Is the emergency department really the appropriate place to do that? Well, in today's system, we don't have an option. That's the only place that we have them taken to. But in new systems, they're looking at other facilities, detox centers, or other resources in the community where they can transport those patients safely. They'll be monitored and they won't be tying up an emergency department bed. This redesign, these aspects of it that go well beyond the traditional roles that we play, the traditional partners that we work with, that is known as mobile integrated healthcare. It's really looking at a better way for us to use the 911 system components that we already have in place and figuring out a better way to deal with those patients that we see that just don't require or don't fit the traditional model of an emergency. But there's another group, another way that we can do this, and that is we can train the providers that are already in the streets, the EMTs and paramedics, to look at their patients differently, to reframe how they view their patients, and to help them navigate and advocate for the patient to get them to the appropriate resources when the traditional system just isn't going to work, like in the case of our 80-year-old pneumonia patient. What we've realized is that the asset in place that we have in most EMS systems is not the ambulance. Sure, that's what the system reimburses us for. It's a medical transportation benefit. But the real value of the current system is in the providers, not the vehicle. And by retraining and repurposing those providers, we can have a much bigger impact on the healthcare system overall. Let's look at some examples of this. In St. Louis at Christian Hospital EMS, they've developed an MIHCP program that's navigated more than 5,000 people away from the emergency department to a more appropriate care setting. As importantly, they've connected 170 people to medical homes. These were people that did not have a PCP that have one now thanks to the intervention of a community paramedic. And as a result of this, they've actually been able to decrease EMS utilization in their most frequent flyers by 63%. In another system, probably the most robust in the country, MedStar Mobile Healthcare has addressed all of these components. They do 911 nurse triage. They look for alternative destinations, and they have a community paramedic program for their super utilizers. And you can see from the data on the screen the impact that this has had on the program and on the healthcare system in Fort Worth. San Diego has what I consider to be one of the most interesting versions of community paramedicine. They have a system in place to help the police department deal with serial inebriates. When you have somebody that's drunk on the streets consistently, they're homeless. What you find is that if you partner that individual with a community paramedic, you can decrease EMS transports and 911 calls for those individuals. But as importantly, you can actually help keep those individuals out of jail. And so we look at the impact of community paramedicine and mobile integrated healthcare, not just from a healthcare utilization standpoint, but from a social justice, from a community resource standpoint, in keeping these people out of prison. And finally, one of the bigger programs in the country, because it was funded by a $10 million grant from Medicare, was the program up in Reno, Nevada, known as the REMSA project. Here they had a comprehensive mobile integrated healthcare system, not unlike Fort Worth. And here are the results of their intervention. More than almost 3,500 ED visits avoided. This is partway through the program. They avoided more than 650 ambulance transports, 60 readmissions. They saved a total of nearly $16 million in charges and $5.5 million in actual payments that Medicare would have made to the healthcare system had those patients been transported there. The interesting thing is that for the $10 million that CMS invested, they got $5.5 million partway through the program back. And that includes the time that it took for Reno to ramp up and really get their program running. The return on investment for Medicare was there in spades, and this hit Medicare's radar. They're very interested in the outcomes of these projects. The Agency for Healthcare Quality and Research, this is a federal entity that evaluates innovation in healthcare systems, has given community paramedic programs that I just mentioned a moderate ranking when it comes to the evidence that they're providing. This is only withheld from a strong rating by the fact that there hasn't been a randomized controlled trial to look at the impact of these programs. This rating is the highest that you can get without the federal government stepping in and sponsoring some of those randomized controlled trials, since they're the largest funding source for many of those programs. In other words, there is a growing body of evidence that these MIHCP programs work. Not only is there a growing body of evidence that these programs work, but there's growing legislation to help enable these programs and help encourage them to grow. 27 states currently have legislation in place that enable CP practices, that allow EMTs and paramedics to practice this new scope of services within their scope of practice. At least 8 more are expected in the next 3 years, including in Pennsylvania. We already have enabling legislation. We are allowed to do community paramedicine interventions, but what's happening in Pennsylvania is that we are moving towards a credentialing system to say that if you're going to call yourself a community paramedic, if you're going to practice in this new role, here are the educational standards that you're going to have to meet. And more importantly, it's going to also allow Medicaid, the state system, healthcare system, health insurance system for the poor. It's going to enable Pennsylvania Medicaid to pay EMS agencies to provide this new service. And that is what's going to be necessary to make this a sustainable intervention. We know the savings are there. We've seen that. We've demonstrated that in other parts of the country and here in Pittsburgh. And what we're hoping is that we can create a new revenue stream for EMS services that doesn't rely on that traditional model to generate revenue, that allows us to do more for the patients outside of the traditional framework that we've worked under for the past 40 years, and do a more effective intervention for patients like our pneumonia patient. Now, I mentioned the program that we've done here in Pittsburgh. Let me share some of the results that we've seen just in the first year or two of our program. Our program is called the Connect Community Paramedic Project. And in a 1-year pre-post design, in other words, we looked at the patient utilization a year before the intervention with us and a year after they had a community paramedic step into their lives. And these are the data that we generated in 205 patients. We avoided 137 ED visits. They had 190 fewer hospital admissions compared to their historical use, for a total savings of around $1.25 million net. That's what we saved when you take the initial grant funds that sponsored the program out of the equation. You're still left with a net savings of $1.25 million, or around $6,000 per patient. Now, there's not many interventions in healthcare that can make claims like this. When you take the skills, when you take the people that are in the existing 911 system and you treat them to look at patients differently, to interact with them differently, you can have a huge impact on their quality of life and on the costs for managing some of the most vulnerable patients in our communities. This is resulting in an evolution of EMS. Mobile integrated healthcare and community paramedicine is no longer considered to be a fad. It's no longer considered to be something that is untested or unproven. It is still at its early stage of development, but all of the early stage resources are pointing in the direction that we can and should be using the EMS providers that we have out on the streets differently than how we have in the past. We can't continue to rely on a system that was built in the 1960s to respond to car crashes to deal with the vast scope of 911 calls that we're receiving today. We have to look at using those resources more intelligently to figure out how we can help people. And so what we're going to talk about in the next series of PowerPoint slides, next week's topics, are what exactly we're doing differently. What is it that a community paramedic does that their traditional brethren don't? How do we look at patients differently? How do we intervene differently? And how can we change our skill set? What impact does the scope of all of these different ways of looking at our patients have on their utilization? But this concludes the first week of PowerPoint podcasts. What you need to do next is go in and look at the discussion topics and start contributing for this week's discussion based on this PowerPoint presentation and based on the briefing materials that you had to read in the PDF file that was attached to this week. And this concludes week 1.